Okay. Hi again, everyone. So we have just finished our first topic, and now we're gonna move on to our second topic for today, which will be presented by Mr. Amir Fariz Zakaria. He is my medical officer. When I was doing my housemanship in Hospital Selayang, so it's very nice to see him that he's a established spine surgeon currently. So he started his housemanship in HKL, followed by MO-ship in Sungai Buloh Hospital. Then he went to complete his a master in HUKM and work in Hospital Sultanah Zahira, Hospital Raja Perempuan Bainon, and he went for his subspecialty training in spine in Murayama Medical Center in Tokyo. So he also has published few papers with some of the his Japanese colleagues. And the interesting part about him is, if I'm one of his Facebook friends, by the way, so you will see a lot of pictures of Iron Man. He joined triathlon competition, cycling competition. So I think this is something that we need to portray, because as doctors, we are always perceived as people who are not very active anymore. So I think this is something which is very interesting, and he has his own triathlon YouTube, if I'm not mistaken. So without further ado, I would like to welcome our second speaker, Mr. Amir Fariz Zakaria, to proceed with your talk today. The floor is all yours.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning to everyone. Can you hear me well, Dr. Nasrina?
Yes. Loud
Okay.
and clear.
Thank you for inviting. It's an honor to be presenting in this new special interest group, Neuro Emergencies Special Interest Group. Interesting talk by Dr. Yo. I was given a talk by Dr. Nasrina regarding double C and inevitable orthopedic emergency. Now that got me wondering what that double C was, until she told me it's actually regarding Conus Medullaris syndrome and also Cauda Equina syndrome. I think the topic of Cauda Medullaris or Cauda Equina, we have heard this repeatedly from our medical students until our MO-ship. But I guess this topic I'm presenting is more like a revisiting again the topic of Conus Medullaris and Cauda Equina syndrome. So what do we know about this Conus Medullaris and Cauda Equina syndrome? We know that it is some form of neurological deficit which is related to the spine injury. We know that it is a spinal emergency. And we also know that any delay in treatment can result in irreversible damage. So the outline of my presentation would be regarding signs and symptoms. And I think I would emphasize most on the signs and symptoms, because this is the main controversies or main issues regarding Cauda Equina or Conus Medullaris, is that we do not recognize the signs and symptoms. And after that, I will talk a little bit on early management, surgery, and summary. So we have seen, I'm sure we have all seen this kind of scenarios, an L1 burst fractures, or a large PID of the L4, L5, or even a spinal epidural abscess. And all this the location of these pathologies are around the lumbar region, which can actually result in either Conus Medullaris or Cauda Equina syndrome. And of course, we will have to talk about the anatomy of this spinal cord. And the spinal cord, I think everybody knows, it ends at the junction of L1 and L2. Well, embryologically, it actually is the same length as your spine. So embryologically, our spinal cord ends all the way near the sacrum. But as you grow older, as we all grow older, the spinal cord stays at the same spot, but then the spine vertebra, the vertebral body elongates, and then it ends then at the level L1, L2. However, it is tethered to this phylum terminale. So there is a band-like pia matter which actually holds the conus medullaris from its original position. And then for the conus medullaris itself, it actually contains the sacral segment of the S2 to S5 of the spinal cord. It has a nucleus in it. We call it nucleus of Onus, which is located at the ventral horn of the S2 or S3 segment. And the conus medullaris supplies the external urethral sphincter and the external anal sphincter, levator ani, and perineal muscles. If you notice, I have actually bold the external urethral sphincters and external anal sphincter, as this is one of the very important function of the conus medullaris. If you talk about the Cauda equina, the Cauda equina itself is a continuation of the conus medullaris, and it is part of the peripheral nerves. And when it goes out of the conus medullaris, it tends to look like a horseshoe, and it is traditionally described as a horseshoe appearance, as you can see in this dissection. And the Cauda equina itself contains bundle of nerves from conus medullaris to the sacrum, which is the L2 to S5 region. Somatic efferent muscles to the muscles of the lower limbs, and somatic efferent containing the vibration, proprioception, pain, and temperature. And also has autonomic nervous system, such as especially the parasympathetic and the sympathetic nerves, which controls your urinary functions. The parasympathetic brings efferent to the urinary bladder from the S2 to S4, while the sympathetic nerve efferent to the urinary bladder from T11 to L2. Apart from that, the parasympathetic nerves also supplies the descending and sigmoid colon, the rectum, and the internal and external reproductive organs. So back to the main question, what do we know about Cauda equina syndrome and conus medullaris? Well, we do know that there is some neurological deficit, and it is related to the spine injury. So I would like to emphasize regarding the symptoms, and it's important for us to detect the symptoms. So I've devised this mnemonic for symptoms, which I call it as SPINS. S for saddle anesthesia, P for pain at the back, P for pain at the leg, incontinence, neurological deficit, and sexual dysfunction. We will be going through these SPINS over and over again for the next few slides. So if you have for saddle anesthesia, the Cauda equina syndrome is more prominent to have saddle anesthesia compared to the conus medullaris. For the conus medullaris, is more of a perineal anesthesia. However, for the Cauda equina, is more of a diffuse anesthesia around the buttock, and we call that a saddle anesthesia. And this saddle anesthesia can also be unilateral in Cauda equina syndrome. In conus medullaris syndrome, there is more complaint of pain at the back. However, in Cauda equina syndrome, there is more pain at the leg, or we call this as radicular pain. For bladder control, in conus medullaris, there is more of incontinence, whereby in Cauda equina, there is more of urinary retention. So I think this bladder reflex, what we know is that the bladder is controlled by the pelvic splanchnic nerve from the S2 to S4. And apart from that, it is also controlled by the autonomic nervous system, the sympathetic, as you know, coming from the thoracolumbar, and the parasympathetic, which comes from the sacral nerve root. Now, the sympathetic helps to relax the detrusor muscles and to contract the internal sphincter, whereby the parasympathetic helps to contract the muscles, and then after that you can actually it actually promotes urination. So I've put it in simpler form in that if you have a Conus medullaris syndrome, there would actually be a detrusor muscle spasticity whereby the external urethral sphincter is flaccid. Hence, there will be incontinence. Okay, but in the Cauda equina syndrome, it is the otherwise, whereby the detrusor muscle is flaccid and the external sphincter is spastic, and then it actually leads to retention. Now, if there is a lot of retention, it can also lead to incontinence, but this would be called as reflex incontinence or overflow incontinence. But the main feature of Cauda equina syndromes are actually urinary retention. In Conus medullaris and Cauda equina syndrome, both presents with neurological deficit. However, in Cauda equina syndrome, the neurological deficit tends to be asymmetrical or unilateral, whereby the Conus medullaris, as you know, it is more central, hence the neurological deficit are actually more symmetrical. And sexual dysfunction, as we can describe it as impotence in men, would actually be more pronounced in Conus medullaris rather than in Cauda equina syndrome. We've seen this before. We've done reflexes for the knee jerks, ankle jerks, BCR anal reflex. These are simplified forms of Cauda equina and Conus medullaris. However, there may actually be some overlapping, as you know, as some of the nerve roots are maybe atypical. So you may. Okay. So in a summary for the symptoms, we can see that for the spinal level of the Conus medullaris, it involves the sacral cord, whereby the Cauda equina involves the lumbosacral nerve root. The Conus medullaris has more pronounced back pain compared to the Cauda equina syndrome, and the motor deficit is more symmetrical in the Conus medullaris compared to the Cauda equina. As I mentioned, the bladder for Conus medullaris leads to incontinence, whereby for the Cauda equina, it is more of retention. And for the reflexes, the knee jerk and ankle jerk are affected for the Cauda equina. However, the reflexes affected are only the ankle jerks for the Conus medullaris. I hope I don't get anybody confused. Okay, so there's an issue with detecting the signs and symptoms. Why there's issue? Because the presentations are so varied. There's so many ways of patients presenting to the ED. And there are also problems with the doctors, with us, that we do not ask enough, and we may also not examine enough. We also do not have an agreed clinical definition of Cauda equina syndrome. So we don't have a point system to actually objectively diagnose a Cauda equina syndrome. So in this one paper, How to Distinguish Cauda equina syndrome, it mentions that there should be one or more of the following symptoms. As I mentioned just now, spins. One or more of the following symptoms, either the saddle anesthesia, the pain, incontinence or bladder dysfunction, neurological deficit of lower limb, or sexual dysfunction. The current method does not only rely on the clinical symptoms, but also you need to do a bladder assessment. You can do a catheter tug, whereby once you insert the Foley catheter, And as you know, the Cauda Equina syndrome, the trousseau muscles are insensitive. So when you tug, the patient does not feel any pain. So that is a positive for Cauda Equina syndrome. Another favorite way of, another more popular way of assessing the bladder is to do a bladder scan post-void residual volume. Now you ask the patient to actually PU, and then you will actually do a bladder scan and assess the volume that is left in the bladder. And there are many papers regarding this assessment. And one of the papers here says that a focused history and physical examination combined with a post-void assessment of bladder volume can assist in identifying cases. Another paper here says that a urinary retention of more than 500 ml alone, or in combination with 2 or more specific clinical characteristics, are important predictors of Cauda equina compression. In this paper, it has shown that, in a normal patient, if you do a bladder scan post voiding, there should be urine retention less than 100 ml. If you have a urinary retention of more than 500 ml, it is almost confirmed that the patient has Cauda equina syndrome. But if you look at this, illustration, at this diagram here, you can see that almost 59% of patients have urinary retention between 100 to 200. And that is also enough to actually give you a suspicion that is actually a that the patient may actually have a Cauda equina syndrome. The next thing that we forget is about the sexual function assessment. And in this paper, are we neglecting sexual function assessment in suspected Cauda equina syndrome? And they audited 120 patients of Cauda equina syndrome, and they found out only 3% had documented sexual function. So we as doctors do not actually assess the sexual function properly. Why? Because doctors are not good at asking about it. And maybe patients are often in too much pain for us to even ask about sexual function. And maybe some patients are very sensitive and they may not prefer to be asked regarding sexual function. However, it is very important to ask because recovery of sexual function is very poor. Now, as I mentioned just now, there are about the important symptoms, which is spins. Now, in this study, involving about 620 Cauda equina patients, they tried to find out which of the symptoms are more common. So then they found out among the spins, back pain is the commonest presenting complaint at ED, 96%, followed by sciatica, 93%, bladder dysfunction, 83%, and so on. But as you know, back pain itself does not necessarily mean it's Cauda equina syndrome. And almost many of us, for acute back pain, we will not think of Cauda equina syndrome immediately. We may think of mechanical back pain, PID, and so on, so on. So having these symptoms does not mean it is sensitive enough to diagnose as Cauda equina syndrome. So how do we know what is a sensitive symptom? In this study, they classified the sensitivity and specificity of the symptoms. And they found out that patients with Cauda equina syndrome with perineal anesthesia, there is about 85% of specificity. Bowel incontinence, 86% specificity. Reduced anal tone is 83% specificity. So these are very specific symptoms that can give diagnosis of Cauda equina syndrome. Apart from not just Cauda equina syndrome, but how about Conus medullaris? Now, the Conus medullaris and the Cauda equina syndrome, since I mentioned just now, the symptoms are the same, spins. But the only distinguishable differences between Conus medullaris and Cauda equina syndrome is the knee jerk. Please remember that the distinguishing signs between the Conus medullaris and the Cauda equina syndrome is the knee jerk reflex. The knee jerk is from the L3, L4 nerve root, and the L3, L4 nerve root exits before the Conus medullaris. Hence, the knee jerk reflex are actually intact in Conus medullaris. The other jerks, such as the other reflexes, such as the ankle jerk, the BCR and anal reflex, are almost the same between the Conus medullaris and Cauda equina syndrome. So take-home message, please remember that knee jerk reflex are actually intact in Conus medullaris syndrome. There are many classifications for Cauda equina syndrome, but none are actually used widely. Like for this, is classification by presentation. It says a rapid onset of type 1 are rapid onset of Cauda equina symptom. Type 2 are acute onset, and type 3 are gradual onset. A more precise or more common classification used are classification by the bladder function. So we divide this into 4. We have a suspected Cauda equina syndrome where the bowel and bladder symptoms are still normal, but however, the MRI shows potential to occur. The second one is early Cauda equina syndrome. Still the normal bowel and bladder function, but the patient starts to present with saddle anesthesia. For incomplete Cauda equina syndrome, then patient starts to have an altered bladder function with saddle anesthesia. And lastly would be a complete Cauda equina syndrome, or we call it as also a retention Cauda equina syndrome, whereby there is loss of all the Cauda equina sensory and motor function. So there are 4 types of classification. So we move on to the next. We know that Cauda equina syndrome and Conus medullaris syndromes are spinal emergency. So what are the urgent things that we need to do? We need to do urgent imaging. We need to improve coordination and ED, and we need to may or may not administer steroids. So I'll talk about it. For urgent imaging, very simple, start with a plain X-ray. Any this is lumbar radio, the spine radiographs can show any bony pathologies, any fractures. MRI is a gold standard, and all patients with suspected Conus medullaris or Cauda equina should do an MRI, should undergo an MRI spine to confirm and localize the lesion. And of course, for those contraindicated for MRI, you do a CT myelogram. There are many etiologies for the Cauda equina syndrome. So once you do an MRI, you will find the cause of this of the pathology. You will find the pathology causing this Cauda equina or Conus medullaris, and 45% of it are actually due to PID. 45% are actually due to PID. There are endless, there's a long list of etiologies that can cause Cauda equina syndrome, in which I will not describe, but in simpler terms, any space occupying lesion in the spinal canal at the level of lumbosacral can cause Cauda equina syndrome or Conus medullaris, any space occupying lesion. I would like to bring attention that not just the patients that present to ED may actually be pregnant patients who are with a gravid uterus. And there are case reports of patients who are pregnant developing Cauda equina syndrome. So always bear in mind patients that have those patients who are pregnant and with a gravid uterus and having back pain. Always take history and find out if they have those spins symptoms, as I mentioned, and examine them as you examine other people as well. Do not dismiss those patients having back pain just and contribute that 100% due to pregnancy. So there are numerous case reports, and I can share one here and another here about Cauda equina syndrome presenting during pregnancy. The second thing I want to talk about is improved coordination at ED. And maybe this one would be of interest to Dr. Nasrina. So, and all the EPs here. So this study, I found that it was done in England by the Charing Cross Hospital, and whereby from this study, it became a protocol in all the National Health Service in UK. So they found out they were trying to find ways to expedite the management of Cauda equina syndrome in the ED through clinical pathway design. So traditionally, the EP would, after taking all the history, physical examination, and suspect there is Cauda equina syndrome, they would have to refer to a neurosurgeon. And then after that, the neurosurgeon will come, and after that, they will refer to the radiologist. And from that pathway, they found out there is actually from the arrival of the patient to ED to the until the MRI films or report available, it takes about 8 hours to 16 minutes. So they were trying to find ways on how to cut this flow. So with increased education of an increase in teaching on how to diagnose this Cauda equina syndrome and Conus medullaris syndrome, and also the EP were able to request for urgent MRI directly to the radiologist, not going through the neurosurgeons. They managed to cut the time to 5 hours and 17 minutes, which is, for me, I think quite significant, but 3 hours difference. So maybe in Malaysia so far, I mean, in my hospitals, the protocol is still a traditional protocol, whereby after the EP sees, then it has to refer to the orthopedic spine or the neurosurgeon. Only then we request for radiologist, and that would take a long time. So maybe if we are really serious in expediting the time to diagnose Cauda equina syndrome, maybe there should also be a protocol from the EP nationally. So then there will be a direct MRI request from the EP. But however, there needs to be an increase in education, whereby the EPs and all the staff in ED will recognize these symptoms of Cauda equina syndrome and Conus medullaris. Now, the role of steroids, very controversial until now. I think any conferences we go, it's just controversial. We normally use IV DEXA, but in my practice, we do it if there is a secondary to tumor. If there is secondary to tumor, then there is an effect of reducing edema. However, if it is other than that, we don't normally use. So again, this discrepancy of using steroids in different hospitals makes it controversial. Even in this hospital, they have given the dosage for dexamethasone. However, again, it is just controversial. Some hospital uses it and some hospital does not. Now, next topic, we do know that a delay in treatment can result in irreversible damage, hence the need for urgent decompression. So now this is where I come in. So for any cases of any case where the Cauda equina or Conus medullaris is compressed, so we do a decompression, either a hemilaminectomy or a full laminectomy with or without discectomy, and depends on the pathology of the patient. If there is fracture, we may or may not stabilize it at the same sitting, and so on, so on. But the main point is, if it is compressed, we will do an urgent decompression. But when is the right time? When is it urgent? What is the timing of surgery? Again, this is controversial. The controversy is because the question arises, at which point does the clock start ticking? Is it from the onset of the Cauda equina symptoms, or from the loss of bladder control, or from the time of admission to the hospital? So we have always, until now, we have been practicing it as an emergency spinal surgery, but there's no strong evidence to support the 48 hours blanket rule. So there are a few predictors for us to go in. We see that preoperative level of neurological dysfunction, a patient with an incomplete Cauda equina symptoms have a better prognosis rather than those having a complete or a retention type Cauda equina syndrome. And so for the retention type or the complete type, there was no difference if you go before 48 hours or after 48 hours. This illustration says that the axonal viability declines 6 hours after compression. Now that is totally impossible for you to go in within 6 hours of presentation. There's no way you can actually go into OT within 6 hours of compression. There are two common pathways for neurological deficit. One is a compression neuropathy. Now, at this compression neuropathy, the tissue is compressed. However, it may still retain the ability to recover its function, but at unspecified time point. So those with a compression neuropathy would still have some form of good recovery. What's not good is the vascular or the ischemic pathway, whereby the compression is beyond the mean arterial blood pressure, and this will cause ischemia to the nerve itself, and this will lead to poor recovery or permanent loss of neural function. A second point or second factor that predicts good outcome is the nature of compression. If the compression is very sudden, very acute, now that means there is actually more force causing deformation to the nerve. And more force means greater tissue and greater microvascular injury. And there would be a subsequent disruption of neural nutrition and recovery. So in acute compression, the neurological recovery tends to be slightly poorer compared to a subacute compression. In a subacute compression, the neurological recovery is much, much better. Other predictors are multi-level involvement, bilateral or unilateral sciatic pain, and presence of saddle anesthesia. So in summary, Cauda equina syndrome and Conus medullaris syndromes are rare disorders. They are rare. And it is a challenge to accurately diagnose Conus medullaris and Cauda equina syndrome, not just because it is rare, but sometimes we don't actually understand the anatomy and the physiology of it. However, I would like to emphasize that you have to remember the symptoms of spins. Please do a thorough history and examination, because even though it does demonstrate poor sensitivity, but as I mentioned, the perianal anesthesia or bladder or rectal disturbance are very sensitive to symptoms of Cauda equina syndrome. Always have a high index of suspicion. As I mentioned, patients who are pregnant, please do not disregard them, and they may actually have Cauda equina syndrome. Management-wise is rather straightforward. Anything compressed, we decompress. And for prognosis, the Cauda equina syndrome retention or complete Cauda equina syndrome have a poorer prognosis. As Dr. Nasrina mentioned, yes, I am an avid triathlete. I've competed in Ironman, but I'm not talking about Ironman, but I just want to talk about the motto of Ironman, which is anything is possible. And we don't have to be an Ironman to understand this, that anything in medical, either the presentations or the management, anything is possible. So always have an open mind when you see a patient, and so then you can actually diagnose them properly. So thank you very much.
Okay, thank you very much, Mr. Amir, for your very interesting talk. I think I learned a lot. That not necessarily you need to have weakness. I thought you need to have weakness for it to be able to diagnose Cauda equina syndrome or Conus syndrome. So I hope that the audience also will have similar impression as we listen through Mr. Amir's talk. So do you have any burning question for our speaker today? You may chat in the box or unmute yourself to ask Mr. Amir personally. Okay, maybe I'll start first. Normally, while taking the history of the patients, because you mentioned that it's very important to take thorough history, correct? So not normally, this is what we normally do. We will ask patient whether can you control your bladder or can you control your bowel movement. But it seems that listening to Dr. Eo's and also your talk, sometimes urinary incontinence also may come with terminal dribbling, for example. So how, up to what extent we shall be asking until we will be able to detect these subtle incontinences that may happen in the patient that you have just mentioned?
I think a clear guideline has been mentioned now recently, is to do a bladder scan. Bladder scan. So I think we, apart from the history of terminal dribbling and so on, that is not conclusive of Cauda equina syndrome or Conus medullaris. A bladder scan is, and it's very objective. So if you see a bladder post-void volume of more than 500, that is a definite Cauda equina syndrome. But even though there is a retention of between 100 to 200 ml, that is also already suggestive of a compression happening. So despite the history of terminal dribbling and all that, what's important is incontinence with followed by a bladder scan.
That's a very interesting input. I think maybe we should learn because I think in emergency you cannot find any ED that doesn't have any ultrasound, I guess.
Yes.
Yes. I think that's a nice thing to be put up for the people teaching ultrasound, life support, and many more. I never thought that it would be quite significant for orthopedic emergencies in this context. So do you have any more questions for Mr. Amir, Fariz? Okay, let me just have a look. Okay, we don't. You mentioned about a reduced anal tone. Sometimes in elderly also they might have some reduced anal tone because of the aging. How do you want to differentiate that?
The Cauda equina syndrome is a constellation of signs. So then you cannot rely specifically on just one. You may need to elicit others on to other signs. So then to confirm it's actually Cauda equina syndrome. I think there are numerous causes for just lax anal tone, numerous causes. But then if there is, to confirm it is Cauda equina syndrome, it must come with other signs and symptoms of Cauda equina syndrome.
Great. Okay. So if we do not have any question, then I think I would like to basically close our meeting today. All right. So tak ada, so I'm going to stop recording.